Good evening, guys. Today we'll discuss another challenging case, but this one is more challenging than the previous one. So let's start by talking about how the case presented. So this is Miss EA. She was a 21-year-old female. Okay, she had no post-medical history. She had fever for 2 weeks. And then she had depressive symptoms. According to relatives, it started almost with the onset of fever, followed by acute behavioral changes over the previous 3 days. Acute behavioral changes in the form of hallucinations and agitation and a little bit of confusion. Okay. She had no history of trauma or any recent infections. Any focal manifestations of infection, and no motor or sensory deficit, no craniopathy or sphincteric abnormalities, and no rashes, and no other manifestations on system review at all, including respiratory symptoms. By the way, just for clarification, this patient came to us in the end of 2020, so it was like in the meantime of COVID, so we were always obsessed by COVID infections. Then on examination, her examination was totally normal. I will just talk about it like in the critical care approach, but it's essentially normal except for the decreased conscious level. So airway was patent and clear with spontaneous regular breathing and no respiratory issues, and her cardiovascular examination was normal. Her Glasgow Coma score was 14 without any signs of lateralization. Her pupils were round, regular, and reactive bilaterally. Her reflexes were elicited symmetrically with bilateral flexor plantars, no signs of meningism, and she had evident confusion and aggression. There was no apparent rash or bruises or bleeding or anything, and her temperature was 39 on presentation to hospital. Okay, so what do you think this might be, and what would you do if you were in this situation?
Can you get back to the previous slide?
Okay. So this is the examination. She was only confused and aggressive with a high temperature, nothing more than this. On examination, I mean.
I think we need to start with like simple labs.
Yes, exactly. Yeah. And anything in your mind? Anything about what may be going on?
Fever itself can cause these symptoms, but what is the reason of fever?
Great.
I think.
Okay, so let's go to the investigations. So basically we did a brain CT scan, which was unremarkable, and a chest CT scan that was like part of the routine screening and baseline imaging for COVID, and her COVID screen was negative, and then the labs. These are the labs, essentially all normal except the CRP, which is a little bit elevated. Otherwise, the rest is totally normal. And it's also like it was a very exhaustive list of labs. Do you want to have a look on the labs or go on?
You can go on.
Okay. Then we sent blood cultures and urine analysis. Of course, like we are thinking of sepsis, and we did a lumbar puncture because the only like focal symptom that we had is the confusion. So we considered CNS infection. And since she had no meningism, no rashes, we thought it most probably it would be an encephalitis rather than meningitis. And it may be viral more than bacterial. So we did the lumbar puncture. The analysis was revealed only lymphocytosis. We started a cyclovir and we sent a viral and bacterial meningitis panel, okay, and we requested an MRI, okay. Here again to clarify, this patient was in Egypt. It wasn't in here in the UK. If this patient wasn't the UK, it would have been much easier to diagnose. But let's go on and see how things will appear, okay. So over the next few days, the patient worsened. Her glaucoma score declined to no eye opening, localization, and sounds. The fever persisted, and the MRI revealed hippocampal swelling with a comment from the radiology consultant. It said that it was suggestive of encephalitis, and the meningitis encephalitis panel was all negative, with all cultures coming back negative as well. Okay, so what do you think is happening here again, and what would you do next?
Probably an autoimmune process in the background.
Yeah, sorry, again, Mohsen, I couldn't hear you.
I mean, it's probably an autoimmune process.
Exactly. That's what we thought of when we reached this this issue, because we had no virus or bacteria that could be identified on the screening tests, and also there was no improvement on acyclovir and antibiotics as well, and it was progressively worsening. So we thought this may be autoimmune encephalitis rather than infective encephalitis. So we presumed this and then started pulse steroids and started also plasmapheresis maybe a couple of days later, because there was no response to pulse steroids at all. Okay, and still after both of them there was no improvement at all. We sent tumor markers and we asked for an abdominal ultrasound. Both came back free, and you remember that we have already done a CT of the chest and it was free. Okay, and she was a young female, so we didn't consider CT of the abdomen in a young female to avoid like any ovarian issues or so on. And then the patient developed bulbar dysfunction and she was unfortunately intubated, and then we needed also to tracheostomize her. Then we asked for a second opinion neurology, and the second consultant requested to repeat the CSF, the MRI, and the oncological screen again. So the repeat MRI revealed mild improvement of the hippocampal swelling and nothing else. So like he thought that there may be some ongoing process that wasn't caught on the first MRI, but actually there was nothing. And then the repeat CSF again showed improvement of the lymphocytosis, and this time we sent the anti-NMDA antibodies and other autoimmune antibodies as well, autoimmune encephalitis antibodies in the CSF. And this came back, I mean the anti-NMDA, the anti-NMDA receptor antibodies came back significantly elevated. Okay, the repeat screening for neoplasia this time revealed a complex right ovarian cyst. So we did an MRI of the pelvis and it showed some tumor, and the radiology consultant said that it may be a cystadenoma of the ovary. So now things began to be more clear. Like you have a tumor and you have also the anti-NMDA antibodies coming back significantly positive. So now things are a bit clearer. So what is this? Of course, I don't mean what is the disease. I mean, what do you know about the disease? Any comment, guys?
I just had a comment, Sharif, about the investigation requested. Why did we thought about malignancy when we didn't have any masses or any abnormal blood investigation that to say that we need to investigate for malignancy? My question is because we found an ovarian cyst, which probably might be an incidental finding. It will make more of a confusion rather than a solution. So what was the rationale behind investigating the whole body for malignancy?
Yes, this is a very good question. You're right that any ovarian cyst may be something like incidentally found, and it may be unrelated to what we have here. But the case with autoimmune encephalitis is that it's strongly associated with malignancy. Especially in young females, it's associated with teratoma of the ovary and other ovarian tumors as well. And generally, it may be paraneoplastic, or it may be associated with tumors, even like benign tumors. That's why whenever you diagnose an autoimmune encephalitis, you have to search for a malignancy.
Yeah, I got it. Thank you very much.
Yeah, thank you. So I will go on with the case. So the anti-NMDA receptor syndrome. Typically, it's a subacute to chronic syndrome of low-grade fever that may be transient as well, okay, and behavioral changes or psychotic features. This is very dangerous because it's usually subacute. Our patient was actually atypical. She had like an acute to subacute onset. Like symptoms developed over 2 weeks, and they were mainly depressive. And then she had 3 days of psychotic features, and then it became worse and worse. But usually this may be subacute, like it may be the onset will be over 1 to 3 to up to 3 months. So it's very gradual, okay, and the low-grade fever may be also transient. It's not essential to be like the patient will present to you with the fever, okay, and symptoms are mainly psychiatric symptoms like behavior changes, psychotic features, depression, things like this. Okay, so most of the times this will be misdiagnosed as a primary psychiatric disease. Okay, and our patient was lucky that she came like with rapid deterioration. So we thought from the start in an organic issue, but like the usual patient will not be treated like this. Typically, it's associated with tumors, whether benign or malignant. Most commonly, it's associated with ovarian teratoma. Treatment, actually treatment is very complex. There is an algorithm for treatment, but it's mainly depending on high dose steroids, plasmapheresis, and IVIG, and tumor removal if present. Most of the time there will be a tumor, then it needs to be removed. If there was no tumor, then just IVIG. Some cases are chronic and they may need further biological treatment like rituximab and things like this. Okay, so this is like basically the anti-NMDA syndrome. So our patient had a laparoscopic oophorectomy, and a biopsy was sent that came back confirming an ovarian teratoma. And we also started IVIG. Okay, and I want to ask you, what do you think happened next to our patient? Now we've already done the correct treatment, but that may be like a month later than the onset. So what do you think happened next?
There was residual neurological damage.
Well, that's what we expected to happen. But fortunately, and very luckily, this patient improved, and improved totally. Over the following days, her conscious level improved gradually till the point that she became fully conscious and could read and write with her right hand. She was already right-handed. She could write, and she could also like make drawings and paintings and things like this. Then she started like expressing her feelings and telling us that she was happy and asking about what happened during the hospital stay and things like this, because she was on a tracheostomy at that time, and told us about things. She wrote down things that happened before, and then we asked her relatives, and they said that truly happened. So she even didn't lose her memory or any sort of retrograde amnesia. And of course, like with this improvement, we expect the respiratory improvement as well. So we could wean her from the ventilator, and the tracheostomy was removed and closed later on. So it was a happy ending, actually. But usually a delayed case like this may never improve, or may improve just only partially with the residual damage. So do you have any comments about this interesting case? No. No, I think there may be some issue with the connection or something. Okay, I'll go on with the clinical pearls from my point of view, and if you want to add anything, then of course you're welcome. So first of all, like the previous case as well, supportive care is the mainstay for survival. So this patient had a long hospital stay before any kind of like definitive treatment. However, she was like supported by the ventilatory support, the physiotherapy, the good nutrition, and also like psychological support as well. So all this made the prognosis somehow better. Also, that sometimes you may need to reconsider your the results of your investigations. Sometimes investigations are done, but they may be not very sensitive. There may be operator dependent, like the ultrasound, and so on. So you need to reconsider things like this. The third one is very important. Like although rare diseases are rare, but seeing at least one rare disease is very common. Also, you shouldn't lose hope. because some patients may respond to the second, third, or maybe like further lines of treatment. This patient didn't respond to the first and the second lines of treatment, and she responded to the third one with the removal of the tumor, of course. Lastly, healthcare fund is crucial. This point is very important because, of course, this case was in a like somehow low resource facility. So that's when I said that this case would have been diagnosed earlier here in the UK, is because when you have an encephalitis, you send the panel for both the infective causes and the autoimmune causes, but this would be very expensive in a low resource facility. That's why some things are omitted because they are rare, but then these patients will be delayed in diagnosis and treatment, and maybe they have, because of this, they may have a worse prognosis. So healthcare fund is really crucial for some patients' survival. And that's it. Thank you, guys. If you want to add any comments, then of course you're more than welcome.
Thank you so much, Sri, for this interesting topic. And I didn't think that this diagnosis should be found in Egypt, to be honest. The first time I heard about it was here in the UK, and I thought like it's something neurology will jump to it and start treating with steroids and plasmapheresis for anything, to be honest. But yeah, it was interesting. And the cases I've seen here, they also had full recovery after prolonged ICU stay with long rehabilitation and tracking. So yeah. I believe it's a true diagnosis now.
Yeah, actually, like when this case came to me as an intensivist, I thought exactly like you, as this was something very rare, and it's like some neurology, you know, the neurology stuff that nobody can understand except neurologists. But as my wife is a neurologist, so when I discussed the case with her, she told me that they meet a lot of these patients in the tertiary care, like the tertiary care service that deals with most of the neurology cases in the like in the area. So they deal with this a lot. So that it wasn't that uncommon like we thought, actually. And also there are some other like subtypes of autoimmune encephalitis that are very easily misdiagnosed as well. So for example, you may have a patient presenting like a Parkinsonism syndrome, or like a cerebellar ataxia syndrome, things like that, and this proves later on to be something paraneoplastic to a tumor or something, and again it's like treated in the same way, like with pulse steroids or plasmapheresis or IVIG, with removal of the tumor if possible, of course. So it's not only the anti-NMDA, but this is the most famous one, because it comes in a young female with a benign tumor as well. It's a benign tumor usually in the case of the anti-NMDA, I mean. Any other comments, guys? Anyone wants to add any more points? Thank you, Mahmoud. Okay, so it seems that like